Hi, I am Tiffany Osborn, and I just want to thank the Sepsis Alliance for asking Nancy and myself to be here to have this discussion with you today. So we're going to be talking about volume administration, finding the right balance. And part of this is going to be discussing where we've come over the last several years and where we are currently. And the information that I'm providing and the analysis of that is my analysis only. I'm speaking only on behalf of myself. So you may be thinking, I'm hearing volume good, I'm hearing volume bad, and it gets a little bit confusing. What am I supposed to do and when am I supposed to do it? What's the bottom line here? And if you feel confused, you're not alone. You have good reason to be. In 2018, consensus report of an expert panel basically said there's really insufficient evidence at this point in time for us to be able to make solid recommendations. And a lot of this is based on our own opinion. And recently with the Surviving Sepsis campaign, there have been some changes in the level of evidence. And so when we talked before about at least 30 cc per kilogram of IV fluid within the first 3 hours, it is still recommended, but it's downgraded from strong to low quality of evidence. And additionally, we're seeing, again, supporting dynamic measures to guide fluid resuscitation after the initial resuscitation phase. And so really the idea here is we're probably not getting this right on either side of the pendulum. And the issue here is that the risk of harm is real, both for over and under resuscitation. So we've seen the results of inadequate resuscitation. And all we need to do is go back to where we were prior to 2001, where we saw that sepsis mortality was anywhere between 30 and 80%, depending on the acuity and other issues associated with it at the time. At that period, sepsis was really not considered urgent, and the treatments that we had for it at that time were really limited. In fact, you can remember if you were caring for patients, I'm sure that there are a number of us who were taking care of people in 1990s and the early 2000s. And there were, when we think about norepinephrine, we thought, another name for that is levofed. And at one period of time, that was considered something else, with levofed. It was associated with the fact that whenever we use norepinephrine, we saw a lot of digits that were not getting, or limbs that were not getting well perfused. And the reason for that was because there was not a lot of volume to press. So how did norepinephrine go from the harbinger of sort of death and destruction to becoming the primary recommended vasopressor in septic shock? What was the difference with that? And I think part of that came from this study when we first realized, one, that sepsis, severe sepsis and septic shock was an emergency, and that there was a consideration of the fact that we needed to make sure that we had adequate intravascular volume. And there was an associated decreased mortality with this at that time, which subsequently was again studied by a process promise in ARISE. So the idea here is that pressure doesn't necessarily equal perfusion. So we can give someone enough vasopressors to create any blood pressure number that's on the monitor that we want. The question becomes, are we actually getting end organ perfusion? So pressure doesn't necessarily equate to perfusion. And our goal, again, is end organ perfusion. And what we found during that whole period is that vasopressors were not helpful when there was insufficient volume to press. And in fact, we could further reduce end organ perfusion if there was inadequate intravascular volume. And at that point, the question became not if volume was needed, but how much. But did we swing the pendulum too far? If you go back again and look at guidelines from that period of time regarding fluids, there was discussion about up to 6 to 10 liters of crystalloid solutions. And interestingly, they talked about in approximately 50% of septic patients who initially present with hypertension, fluids alone will reverse hypertension and restore hemodynamic stability. Well, what that makes you think about is that if 50% responded, then 50% did not respond. And this is a meta-analysis where they looked at volume responsiveness in intensive care unit patients and found that only about 50% of patients were responsive to intravenous fluid boluses. This was looking at 50 ICUs, around 2,200 patients. And there are, just as there are complications associated with decreased intravascular volume, there are also consequences when we are hypervolemic. And we all have seen abdominal hypertension. We know about increased acute renal insufficiency associated with this. So there are complications and real risks of harm on both ends of this dynamic. So what's the difference between enough and too much? And how do you walk that line? Where do we balance how much, when, or if we're administering fluids? So one of the things that I did like about this consensus report is they do suggest defining a common language, which I think is one of our key indicators that can help. And that's the difference between fluid loading during resuscitation and a fluid challenge in post-resuscitation volume. And with that, what we're thinking about here is what is the optimal volume for the individual patient, because every patient has unique and consistently changing hemodynamic needs. How do we understand a patient's volume status throughout their care and provide what they need, but not more than what they need? So I think one of the things to consider is if somebody is presenting in duress, then this is a period of time where we're doing fluid loading. This is a time where we're looking at true resuscitation, and we're going to give a volume bolus. And then once they've stabilized some, go back and consider how we're going to do fluid challenges. In our post-resuscitation, we're a little bit more stabilized, as I was saying, and this is the period where we're looking more at how are we going to individualize our volume administration. And I think FRESH, the study with fluid response evaluation in sepsis, hypertension, and shock, this randomized trial does provide some insight on this. So when we think that they looked at clinically determined sepsis with greater than or equal to 2 SIRS criteria, in conjunction with refractory hypertension that was persistent after a minimum of 1 liter of fluid administration. And the key component here is that they were allowed to get between 1 and 3, but if they got over 3 liters, the patient was excluded from the study. And they were enrolled within 24 hours of hospital arrival. So the key here is that this is a post-resuscitation study. So they enrolled 150 patients over 13 sites, and you can see that they assessed eligibility. They are randomized. 102 were randomized to the intervention. 48 were randomized to usual care, and within the analysis, 83 were from the intervention. 41 were in usual care. So what was the intervention? When we're talking about this intervention, what exactly was that? And so after this, volume bolus that the patients initially received during their immediate acute resuscitative phase, if there were a reason why the clinician felt more volume was needed, such as low blood pressure, low urine output, or you're starting to increase on your vasopressors, what you would do first prior to a fluid bolus was to do a passive leg raise fluid assessment. And so they were looking at the stroke volume change. So if the stroke volume change was less than 10%, then that said not fluid responsive, and that patient would then have vasopressors titrated. If it was greater than 10% stroke volume change, then it was considered to be volume responsive, and they would get 500 cc bolus, and then they would retest with another passive leg raise to determine whether or not they were going to continue to give fluids if the patient still looked like they needed it. Now, when we talk about passive leg raise, what are we talking about? And it's not real complicated. I mean, you start off with the head up, you get a baseline, and then you bring the head down and the legs up. So fluid administration then is based on the responsiveness of the patient at that point in their resuscitation. So what are their needs as the patient is moving forward in their own journey? And again, responsiveness here was considered a stroke volume change of greater than or equal to 10%. Now, how do we know what a stroke volume change of greater than or equal to 10% is? Well, you can use ultrasound, although that can be challenging at times, both because of time limitations and because of inter-user variability. But you also have the Starline monitor, and you can see here, this is what the monitor looks like. And these are the non-invasive sensors that get placed on the patient. And the monitor tells you where to place these on the patient. And then after you have run this baseline and then with the legs up with a passive leg raise, it gives you the time at how long you need to wait until you run the second set of numbers, but it will give you a screen that looks something like this. And so in this case, the percent of stroke volume change was 30%. It shows you the Frank-Starling curve here. If it's on the lower side, then they're volume responsive. Shows you here, where you are at baseline and where you are after the passive leg raise challenge. And you're now measuring, you have some sort of data that can give you information about what this particular patient needs at this particular time. And this is what they were using in this study. Now, what happened with that? And so they got about 2.4 liters, 2.2 liters, so just over 2 liters in both. So that equated to around 30 milliliters per kilogram. And you can see that these are the primary endpoints that demonstrated a significant difference. And one was fluid balance at 72 hours. There was a difference of about 1.68 liters or so, the requirement for renal replacement therapy, and the requirement for ventilator use. So what happened after this post-resuscitation phase when they did the fluid loading after that immediate resuscitation? And what they found was that they had less dialysis that was required. So about a third of people required that. And then there was less mechanical ventilation, around half. And no change in their endpoint for ICU length of stay. So when we're thinking about volume, unless there is an alternate clinical reason, in the acute phase, you can consider fluid loading anywhere between a liter to 30 cc per kilogram, depending on the patient that you're dealing with and their response to that volume. Then we can consider fluid challenges, a dynamic type of assessment. I think that we're still trying to ascertain. We think that this initial fluid bolus in most patients appears to be safe, but that's not a universal dictum. There may be some individual patient populations where it needs to be reconsidered. So following that fluid load with fluid challenges appears to also be helpful in reducing the total amount of fluid that's provided and the endpoints of renal replacement therapy and mechanical ventilation. And I just want to say to all of us who have been working really hard with the COVID issues over the last year and a half, that your work is really valued, and thank you so much for everything that you've been doing. It really does make a difference. Thank you. At this point, I'm going to turn it over to Nancy Bickel.
Hi, this is Nancy Bickel, and I too want to thank you for the opportunity to talk to you about this important topic, and most certainly a timely topic as we work through this change in the healthcare environment that we've faced over the last couple of years. So as Dr. Osborn's talked about, the hallmark of sepsis management, I think of it as a tripod. You've got to treat the infection. You've got to treat the dysfunctional host and try to modify and support the host responses to that. But at the heart of the whole thing is we've got to restore tissue perfusion and end organ perfusion. And that's where the fluid management comes in. When we think about the different types of shock, by far the most common type of shock is going to be distributive shock, or think of septic shock. And the focus of the management of the patient that's in a distributive shock is certainly preload, assessment, management, accurate management, and management of preload, and certainly fluid status. And we've talked, Dr. Osborn talked a lot about this, but the importance of the accurate assessment and fluid administration can't be overemphasized. Too much versus too little are both going to be leading to negative patient outcomes and increased mortality in these patients. So what's the right balance? How do we figure out with concrete data what's the right fluid resuscitation and then ongoing management of the patient, and specifically the sepsis patient? As a nurse, and a nurse who's been around for a while, I will tell you, when I think about the history and how it's changed how we assess the patient's, not just fluid status, but in general, their hemodynamics is just fascinating to me. It goes all the way back to the early in the 1900s with the sphygmomanometers. And then the advent and having a surgical critical care background, CVP was the hallmark of assessing preload in patients. And I'm one of those new grads who went straight to the intensive care unit after graduation. And we had a very large, very active surgical intensive care. And that's where I developed my love for surgical critical care. So I remember CVP. And then I remember when PA catheters came into play. And everybody had a PA catheter. We used to laugh that if you stood still long enough, you were going to get a PA catheter put in. But we'd float them at the bedside. And now we've developed bedside echo cardiograms and ultrasound, moving into the less invasive and even non-invasive technology, which has enabled us to do a better risk-benefit analysis on some patients that is just not feasible to be inserting things and doing procedures on some patients. At our organization, we have a very large transplant population. We have a very large oncology and BMT population. And you can't just put PA catheters in these patients. You can't just even esophageal Dopplers, which I can remember when we used those quite readily as well. So when you think about the advent of the technology, and as we move to the non-invasive, we've been able to incorporate a lot more patients that it may not have been feasible to do prior to that. So it's pretty fascinating. So Merrick and the various groups talked about there's been a lot of studies, and Dr. Osborn alluded to those. When did we quit using CVP as the hallmark for preload? And what we found, you got to define it, to research it. And what we found is that the CVP really is not that well correlated to total circulating volume. And so it really doesn't tell us what we thought it did, especially in the septic shock patient and when we're talking about fluid balance. So there really is no data to support the widespread practice of using the CVP to guide fluid therapy. And at our organization, we have very much moved away from that. We've tried to incorporate the newer technology and especially the dynamic assessments to better assess our fluid resuscitation. So just briefly talking about static versus dynamic assessment, and to not say to get rid of everything, but apply them appropriately at the bedside for the patient population that you're caring for, but specifically maybe that particular patient. So static parameters really only tell you about the current hemodynamic state. So CVP, wedge pressure, jugular venous pressure, systemic and peripheral vascular resistance, BP, MAP, urine output, left ventricular ejection fraction, right? RV function, the flow time, and mixed venous, as opposed to the dynamic responsiveness and to therapy. And that really is where the fluid responsiveness comes in. So pulse pressure variation, passive leg raise, which Dr. Osborn spoke about, IV fluid boluses. A lot of us, let's give them a bolus and see how they do. Well, maybe. IVC inferior vena cava diameter variation using bedside ultrasound, inotrope responsiveness, and vasoresponsiveness. So really, the accuracy comes in the use of dynamic assessment and using that information in addition to the static parameters that we use. So there's pros and cons to all these modalities. Many of them have limitations, and especially related to patients who are not on mechanical ventilation. So pulse pressure variation, stroke volume variation, IVC diameter, and expiratory occlusion pressures. They require a TEE, but they also can't really be done on patients that have spontaneous respirations that are not on mechanical ventilation. We know cardiac output's the best predictor, especially when utilizing passive leg raise and in combination with the fluid challenges. But think about some of these other methodologies. If they don't have white cells, if they're leukopenic or thrombocytopenic, we can't be arbitrarily just inserting invasive cannulas and different monitoring devices into these patients. Monet and that group actually looked at the sensitivity and specificity of the different modalities, most specifically the dynamic. And the passive leg raise ended up being the best sensitivity and specificity at a 95% confidence level. So that's where it's easier, it's quick, and it gives you the best information. So PA catheters, unknown or explained volume, status, and shock. We're going to use PA catheters still in the cardiology population, severe cardiogenic shock, severe underlying cardiopulmonary disease. I can think of patients, post-op patients that are also in cardiogenic shock, and we did go ahead and put a PA catheter in. So again, there's that combination and the different teams coming together, guiding the use of vasopressors and inotropes, diuretics, those kind of things. So they do still have their uses, but remember the information is somewhat limited. Stroke volume variation, it's comparable. Pulse pressure variation, but they're not actually indicators of actual preload. It's a relative preload responsiveness. They do have high sensitivity and are used, especially in our institution in the surgical population. Pulse pressure variation, got to have an art line in. And so it's looking at the variation induced by mechanical ventilation. If you have a spontaneously breathing patient, you can't use it. and then bedside echo. Bedside echo is most fun when you're looking at the contractility and the squeeze factor for the left ventricle, looking at fluid responsiveness. Systolic dysfunction does not mean that you can't have a dilated RV. However, I will tell you that bedside echo, we have an academic emergency medicine program at our institution, and it is still the hallmark first line evaluation in the emergency department. In the initial evaluation, especially in the resuscitative phase when we're resuscitating the sepsis patients. And then we get to passive leg raise. So it's very useful. I've talked about the sensitivity and specificity for predicting volume responsiveness. You can use it in most any cardiac rhythm. And you're looking for a delta. The studies show that the highest correlation was between 9 and 15%. We do use 10%. And the fresh study, as Dr. Osborn spoke about, looked at a delta of 10%. So it is probably the best. Monet and group put together sort of a decision-making algorithm looking at the assessing the responsiveness to fluid administration, and incorporates the limitations of the various modalities, especially passive leg raise and expiratory occlusion test, mini fluid checks. But you got to keep in mind, especially in our COVID-19 phase right now, you've got to be able to look at both intubated, non-intubated patients, and with the high volume of ARDS patients, a lot of these can't be used with an underlying ARDS, where a passive leg raise can. Dr. Osborn spoke about the fresh test already by Douglas and that group, and it looked specifically at the 24 hours after arrival. And it didn't look, I mean, sepsis is a time critical diagnosis, just like STEMI, just like stroke, just like trauma. We've made that the fourth time critical diagnosis. And I think there's still a lot of work to be done looking at the resuscitative phase, but the fresh study very adequately talks about that the fluid challenge phase that Dr. Osborn spoke about. They use the passive leg raise as the modality to evaluate the fluid responsiveness in this clinical algorithm. And it included both fluid and vasopressor response. And I just want to comment again, the importance of accurate assessment and fluid administration. Overload can be just as dangerous, if not more, higher mortality than fluid overload. So Baxter Starling system is a very easy system to use. It's quick, it's accurate, and it provides the clinician with that dynamic fluid assessment that once you get it set up and leave it on. The way we've implemented it in our organization has been, I call it nurse-driven. When we're assessing the cardiac output, assessing the responsiveness, especially of the patients, then we just go ahead and put it on and tend to leave it on. Yes, you have a limited number of monitors, but we want to do ongoing assessment and add that to the trajectory of the patient, that information. Setting it up, applying the electrodes, then doing the passive leg raise is accomplished very quickly and accurately. And it comes with a lot of practice, which has its challenges. Dr. Osborn talked about the 2021 Sepsis Guidelines that were published recently in the October Critical Care Medicine Journal, and talked about the differences of how we downgraded that fluid assessment, but most especially talking about the use of dynamic parameters. I remember back when the guidelines originally came out, and they had very concrete CVP of 8 or above, et cetera. The MAP has to be 65. MAP still is 65, but they were mostly static parameters. And now we're talking about the use of the dynamic parameters and using them according to the individualized patient. So I think we made a lot of headway. So in general, what's the right balance? The balance is challenging. Introducing new modalities to the staff in today's healthcare environment, with the nursing shortage, with the turnover of nursing, with being floated to other units, And that's our reality. That's what it is. So being able to move people and teach them quickly these new modalities and the difference between the dynamic assessment and the static assessment and how you need the whole cadre of outcomes in the patient. Understanding the limitation and benefits of each of those modalities as it's applied to the patient population that you're caring for. What's the best tool for that specific patient population? And in the case of the PLR, is it a tool that's very widely applicable and it's pretty easy to use? Bad data is useless, if not dangerous. So basing your treatment decisions on incorrect assumptions and incorrect data is very dangerous. The challenge comes in maintaining the provider competency and comfort with the modality, and as well as the nursing competence in today's healthcare environment. We have a lot of travelers and agency nursing staff. I will admit my daughter is one of them, and providers being pulled to units they don't typically cover. If you're a surgical attending and you're being pulled to the medicine ICU, and let's face it, we're doing it. We have overflow of certain types of patients in units. We have very highly specialized ICUs at our organization. If you're a general ICU, you're used to seeing all of them. And so with that, I want to just leave you with the challenge, and I don't have the answer for that. I wish I did, is how do we maintain our nursing staff so we retain our nursing staff, but retain those competencies and their comfort with the modalities that we're using? And I haven't quite gotten to that answer yet, other than being at the bedside, supporting them in doing so, and a lot of resources available. So with that, I want to thank you for this opportunity to speak to you about such an important topic. And I hope to work with all of you as we continue our endeavors at reducing sepsis mortality and talk about patients that virtually touches every single clinical service and every single unit in our healthcare facilities. So thank you.